Hello everyone, welcome to my YouTube channel. Today my topic is dilated cardiomyopathy. I will discuss a clinical scenario and related MCQs. Now, a 1-year-old male arrives in the emergency department with a 4-day history of vomiting and abdominal pain. His mother states that he has low-grade fever, decreased appetite, and has been breathing fast and hard. On examination, he is cool with delayed capillary refill. He is alert and answers questions appropriately. His heart rate is 150 beats per minute and respiratory rate is 60 respiration per minute. On abdominal examination, his liver edge is 4 cm below the right costal margin. On cardiac auscultation, he has occasional irregularity and a gallop, but no murmur is heard. He has mild subcostal retraction with coarse lung sounds throughout. Now the questions. Question number 1. Which of the following is most likely diagnosis? A. Pneumonia, B. Viral gastroenteritis, C. Aortic valve stenosis, D. Dilated cardiomyopathy, E. Dehydration. And the correct answer is D. Cardiomyopathy. Cardiomyopathies are diseases of the heart muscle characterized by abnormal findings of chamber size and wall thickness or functional abnormalities. Cardiomyopathies can be either primary, which are confined to the heart muscle, or they may be secondary, in which the myocardial damage is due to a systemic illness. Most common cardiomyopathy in children is dilated cardiomyopathy, which is characterized by left ventricular systolic dysfunction with an increase in the left ventricular size. Mitral regurgitation and ventricular arrhythmias can develop and can be present at the initial presentation. Dilated cardiomyopathies can present with signs and symptoms of congestive heart failure, diaphoresis, breathlessness, abdominal pain, and pallor. Young children often present with abdominal pain, vomiting, and anorexia due to mesenteric ischemia. On examination, these patients may have sinus tachycardia with or without ectopy, a gallop rhythm, jugular venous distension, hepatomegaly, and a murmur that is consistent with mitral regurgitation. Pneumonia can present similarly with vomiting and increased work of breathing, and if infection is severe and leads to bacteremia, patient can present in septic shock. If infection leads to lack of oral intake and fever leads to insensible fluid loss, child could be dehydrated, but child in the above case has hepatomegaly out of proportion to the symptoms and signs consistent with the infection. Child also has a gallop rhythm and irregular heartbeat due to the ventricular ectopy, which is inconsistent with viral gastroenteritis or bacterial pneumonia. Now, a child with aortic valve stenosis would not present to emergency department in shock. Aortic valve disease is usually detected on a routine examination when a systolic ejection murmur and click is heard. It would not account for the many signs and symptoms of congestive heart failure that are present on this child examination. Question number 2. A chest X-ray is obtained which reveals a large heart with mild pulmonary edema. Vital signs remain stable and the child is neurologically appropriate. Which of the following is the most important diagnostic test to perform next? A. Blood culture, B. Echocardiogram, C. CBC with differential, D. Computed tomography of the chest, and E. B-type natriuretic peptide. And the correct answer is B, that is echocardiography. Diagnosis of cardiomyopathy is dependent on the patient history, physical examination, and echocardiographic features of the dilated cardiomyopathy. Echocardiogram should be confirmatory and done quickly to assess the severity of the ventricular dilation and systolic dysfunction, but should not interrupt close monitoring and rapid initiation of the additional therapy. On echocardiogram, ventricular size will be measured, ejection fraction calculated, and presence and severity of mitral regurgitation will be determined. Patients presenting in this degree of failure often develop cardiogenic shock quickly after the arrival and require rapid escalation of therapy. They are also at risk of life-threatening arrhythmias. Computed tomography of the chest would show a large heart but would not be able to estimate the severity of the dysfunction. It would not be safe to place this child in a CT scanner until he is supported and well compensated. Laboratory tests listed above may be done to guide the future therapy, but are not necessary for the initial diagnosis or management. A BNP may help differentiate between the myocardial disease and pneumonia, but it is not the sole test necessary to diagnose a cardiomyopathy. Question number 3. A bedside echocardiogram demonstrates severe systolic dysfunction with moderate mitral regurgitation. Child is breathing quickly but has a stable blood pressure. Perfusion appears adequate and he is interacting appropriately. Now, what is the initial class of drug to be prescribed? A. Diuretics, B. Angiotensin converting enzyme inhibitors, C. Anticoagulants, D. Phenylephrine, and E. Narcotics. And the answer is A, that is diuretics. Therapy of dilated cardiomyopathy is mainly directed at the treatment of heart failure related symptoms and prevention of disease related complications. Treatment of decompensated heart failure is focused on diuresis with loop and thiazide diuretics for volume overload and afterload reduction. This child examination is concerning enough that starting an oral regimen with ACE inhibitors would not be appropriate. Although anticoagulation will be important eventually, it is not the first class of drug to use. In decompensated heart failure, systemic vascular resistance is elevated and initially blood pressure will be maintained even if overall cardiac output is poor. Further increasing the systemic vascular resistance will increase the afterload on the heart and lead to further decompensation. Eventually, after resuscitation, goal will be to optimize the outpatient heart failure management with an ACE inhibitors and a beta blocker. In addition, patient will require anticoagulation to prevent the thrombus formation in the dilated left ventricle. Now, question number 4. Infant is transferred to the ICU and there he becomes extremely tachycardic and start to act very agitated. His blood pressure is high but his perfusion is poor. What is the appropriate therapy for this patient who is now showing progressive evidence of poor cardiac output, including changes in the neurologic status? A. Phenylephrine, B. Beta blocker, C. Benzodiazepine, D. Intubation, and E. Narcotics. And the correct answer is D, that is intubation. Intubation and positive pressure ventilation will decrease the afterload on the left side of the heart. It will now be safe to sedate the child in order to decrease the oxygen demand and allow for optimization of the child's cardiac output. Intubation in these children is not without risk and therefore should be performed in a controlled manner with appropriate personnel and resuscitation drugs close by. If perfusion does not increase with initiation of positive pressure ventilation or child become hypotensive, then further therapy is warranted. If the blood pressure is adequate but perfusion is poor, modulation of afterload should be attempted with vasodilator therapy such as nitroprusside or with milrinone, which will provide inotropic support and vasodilation. In children with heart failure and hypotension associated with hypoperfusion, continuous intravenous epinephrine should be considered. Now, although sedation may decrease oxygen demand and calm an agitated child, but in patients with heart failure, it may blunt catecholamine surge that is required to maintain the cardiac output and lead to a rapid decline and cardiogenic shock. And lastly, increasing afterload with phenylephrine with no additional inotropic support will lead to further deterioration. Thanks for watching this video. Please subscribe to my YouTube channel.